And I was fascinated by the presentation of Dr. Dalal because he had a slide that included the phrase, can we do it, should we do it, which are not the same question. Can you PCI most patients with multivessel disease? Yes. Should you? No. These are my disclosures. And this is the rationale for my debate. Coronary bypass has beaten PCI in every randomized controlled trial with long-term follow-up greater than 5 years, and I would argue that no trial that is followed for less than 5 years should be considered valid or informative of this question. CABG has consisted mostly of one arterial graft and vein grafts on pump with aortic clamping, and that kind of coronary bypass can be dramatically improved with presently available technologies and techniques, including multiple arterial grafts, minimal aortic manipulation, intraoperative graft quality control, etc. You cardiologists should drive your surgeons to do a better job at CABG. They're not doing the best in most centers. FFR guidance has not clearly improved either PCI or CABG. Indeed, FFR-guided PCI is not better than angiographically guided PCI, and FFR has no validated role whatsoever in guiding CABG. Moreover, attempts to downgrade multivessel coronary bypass with FFR and then assign patients to PCI rather than CABG are logically invalid and clinically inappropriate. The physiologic benefit of CABG, which is protection against present and future lesions, and the consequences of graft failure, which is often silent, are very different from the physiologic benefit of PCI, which is treating present proximal disease, and the consequences of stent failure, which is typically myocardial infarction. CABG will beat FFR-guided PCI for most patients with multivessel disease, irrespective of improvements in stent design, especially if CABG is performed with best practices. So let's look at some of the present guidelines. This is to improve survival compared with medical therapy in unprotected left main or complex coronary artery disease. You can see it's a class 1 recommendation. In 3-vessel disease, for either CABG or PCI, for 3-vessel disease, with or without proximal LA disease, it's a class 1 recommendation for CABG, class 2B of uncertain benefit for PCI. To improve survival compared with medical therapy in 2-vessel disease with proximal LAD involvement, class 1 for CABG, class 2B for PCI. In 2-vessel disease without LAD involvement, class 1A for CABG, 2A for CABG, 2B for PCI. In patients with multivessel disease who also have diabetes, it is reasonable to choose CABG with LEMA over PCI, a separate statement. This is to revascularization to improve symptoms with significant anatomic or physiologic stenoses. Note in complex 3-vessel disease, i.e. syntax score greater than 22, with or without involvement of the proximal LAD and a reasonable candidate for CABG, CABG is preferred over PCI. Here are the European guidelines for 2-vessel coronary artery disease without proximal LAD stenosis, 2B for CABG and 1 for PCI. With LAD stenosis, 1 for each. In 3-vessel disease without diabetes, 1 for each. And class 3 for 3-vessel disease with an intermediate or high syntax score greater than 22. So let's go over that again. For multivessel disease with either intermediate or high syntax score, PCI is contraindicated class 3 harm in the European guidelines. Similarly, with 3-vessel disease with diabetes, intermediate or high syntax score, class 3 harm for PCI. So in a sense, this is a very unfair debate. The guidelines on both sides of the Atlantic would say that Dr. Colombo has an impossible task. This is the summary of the European Guidance 2018 favoring PCI because I think there are patients who should have PCI, as I mentioned earlier. Advanced age, frailty, reduced life expectancy. Let's be straight. Most of the CABG PCI comparisons, the curves don't begin to diverge until 2.5 to 3 years, and they're quite different at 5 years. We'll show those shortly. If the patient's life expectancy is 3 years, he should have PCI, or she should have PCI. If the patient is 50 or 60 or even 70, they should have coronary bypass. Here are some of the data backing up those statements. This is Dr. Fuster's slide from the Freedom Trial 5-year data, and you can see that these curves are not just diverging, the divergence is accelerating at 5 years. That for the combined endpoint of death, stroke, and MI, not repeat revascularization, just a hard endpoint of death, stroke, and MI, CABG greatly outperformed PCI beginning at about 3 years and dramatically so at 5 years in diabetic patients, a large cohort. This is the Freedom Trial at 5 years. Death also different, not just the combined endpoint, but death alone different at 5 years with a significant p-value in favor of CABG. And at 7 years, that long-term survival holds and appears to be continuing to diverge. Once again, the treatment difference wasn't apparent at 2 years, was apparent at 5 years, and remains at 7 years. And it applies to all patients. It applies to patients with intermediate or high syntax score in a significant way. It applies to 2 and especially 3 vessel disease where CABG is better. In the Freedom Trial, again, the same 7-year data, it's especially apparent in younger patients. So if I send you cardiologists home with any idea, please expunge from your vocabulary the notion he's too young to send to CABG. Send the young guy to CABG. The 80-year-old little old lady who just needs to get to the bathroom from her couch and has classic surgical anatomy, think twice about whether she should have CABG. Maybe she should have a focal PCI and go home. Here's syntax trial at 5 years. For mortality, no significant difference. For myocardial infarction, a benefit of CABG. Repeat revascularization, a benefit of CABG. Death or stroke or MI, a benefit of CABG. MACE in general, a benefit for CABG. Note at 5 years, no difference in stroke in the syntax trial. This is for multivessel disease only in the syntax trial at 5 years. Low syntax score, the curves overlap. Intermediate and high syntax scores, MACE is strongly in favor of CABG over PCI. And indeed, if you look at the consequences of stent failure and graft failure, they're quite different. In those patients who did have stent failure, these are the outcomes, 30% cardiac death. In those who had graft failure, mostly just revascularization, typically by PCI. And that syntax trial was followed in an incomplete basis thus far, and Patrick himself gave me these slides. In the 3-vessel group, you can see a highly significant comparison in favor of PCI for just mortality at 10 years follow-up. And this is almost 9%. It's almost 1% per year. Let's go over that again. It's almost 1% per year absolute difference in mortality during longer-term follow-up of patients with 3-vessel disease. That should be in the consent. An informed consent to do PCI on a patient with multivessel disease should include you will have a 1% per year difference in mortality with PCI versus CABG. This is the Excel trial. It looked at 3 years like it wasn't going to be very different, but which of these curves would you rather be on? What will these curves look like at 5 years? Will they look like this? Is this what we're going to hear about at TCT? We know that at 4 years, there was actually a difference in mortality between these two groups in favor of CABG. But yet, we still pump out data, or papers talking about the 3-year data set rather than the 5-year data set. And I'm told that the trial sponsor is refusing to follow the patients for 10 years. That's censoring medical information, putting a lie to the notion that that corporate-sponsored trial was actually academic. These are the Noble trial results. Another left main trial done in Scandinavia. PCI did not meet non-inferiority. CABG outperformed PCI for MACE with a difference of about 10% at 5 years. For all-cause mortality, a difference of about 3% at 5 years. MI, about 5% at 5 years. Repeat revascularization, 5% at 5 years. Stroke, weirdly, was worse in PCI than in CABG for those patients. And a recent summary, or meta-analysis in Lancet 2018 with a variety of important cardiology contributors, Patrick Surais, Greg Stone, etc., Valentin Fuster, demonstrate that mortality at 5 years is simply higher in PCI over CABG, especially in patients with multivessel disease. So I'll argue that we need to, the cabbage is better than PCI for most patients with multivessel disease, but I'll also argue that we need to do a better job with cabbage. There are differences in the physiology of cabbage versus PCI. Cabbage protects the whole flow to that territory through surgical collateralization and protects against future lesions that may occur upstream of the bypass graft. And I think this is a fundamental physiologic difference. It's no fault of PCI. It's simply a fact that non-flow limiting lesions often cause events later on, and they're protected by coronary bypass grafts, especially arterial grafts, and not protected by stents. How can we make cabbage better? We need to use more arterial grafts. These data are very old but largely ignored. They're followed for 20 years. Beta outperforms theta. We showed this in diabetic and non-diabetic patients at Emory University, where I worked some time ago. And the ART trial, the large randomized trial, in the as-treated analysis, because there was a huge amount of crossover in that trial. In as-treated comparison, this is mortality in 10 years, single arterial versus multiple arterial grafts. Patients with multiple grafts lived longer and had better avoidance of MACE. Yet in the national database, 5% of patients get 2 arterial grafts. This is shameful. Similarly, in the New England Journal very recently, there's a paper that tells us that radial artery grafts, rather than just vein grafts in addition to edema, have a better outcome in terms of death, MI, and revascularization at 5 years because the grafts fail less frequently. Here's angiographic failure rates, and require less repeat revascularization, and yet the use of radial artery grafts in the United States of America is about 5%. This is shameful. The more vein grafts are used, the worse the outcome of coronary bypass surgery. This is a really interesting paper by Umberto Benedetto demonstrating that from the ART trial database. If we look very carefully at how to do coronary bypass, whether it's on pump, off pump with a partial clamp on the aorta, off pump with a facilitating device, or no aortic touch surgery, we see in this interesting comparison that anaortic off-pump bypass outperforms standard CABG, 80% reduction in stroke, 50% reduction in mortality. But it's still very infrequently done. This is what it looks like, actually. This is our standard operation at Mount Sinai St. Luke's, double mammary grafting and a radial artery graft, an all arterial, no aortic touch, complete revascularization. This is done in less than 1% of cases in the United States of America. So coronary bypass has not put its best foot forward. I applaud my interventional cardiologists because they're really rigorous about improving what they do in every possible way. Finally, can FFR-guided CABG be equal to angiographic guided CABG? There's only one randomized trial. It was halted at 6 months, had 6 months follow-up. It was halted because of poor enrollment. It showed no difference between FFR-guided CABG and angiographic guided CABG. Interestingly, Patrick Sorois presented at EuroPCR the fact that heart team assessment based on computer or CT FFR or conventional angiography was surprisingly similar, so it doesn't seem to make much difference. However, the future trial would argue that FFR added to PCI makes the outcome worse. Here's all-cause mortality, much worse in the FFR PCI group rather than the angiographic PCI group. So I would argue again that CABG for most patients with multivessel disease is the right way to go. Good luck, Antonio.
Oh, that's a good one.